So when you look at what we call operating margins, we saw that operating margins have dropped. In 2020, there was a positive margin. It wasn't a huge margin. It was $1.4 billion, but that was about 4%. But by 2024, health centers were operating in the red.
Hello, one and all, and welcome back to The Rural Impact. I'm Michelle Rathman, and as you know by now, we are the podcast that does work hard to connect the dots between policy and rural everything, or as we like to say often, rural quality of life. We are so glad that you have joined us today. It is our last episode of the year 2025, and oh, what a year we have had together. I believe, by count, we've probably done 25 episodes or so covering a wide range of issues. And as we always do, our guests on every episode are thought leaders who have a deep understanding of policies that all too often paint rural out of the picture. We aim to change that. So before we started recording today, I went back to refresh myself on where we started off this year. And lo and behold, we kicked off 2025 talking about a subject that we will end the year with, and that is health policy. And I know we've been talking about that a lot lately, because if you've been paying attention to any of the headlines, you know that the world of healthcare is in a world of uncertainty as we are recording this today on December 8th. And of course, you're hearing this on December 18th, and we still don't quite know what's going to happen with the ACA tax credits expiring and a plan from the Republicans on healthcare. But I have no crystal ball. Based on the headlines I'm reading, we are going to be doing some nail biting the next few weeks. So we shall see what happens. Of course, news happens fast. This might change by the time you hear it, but nonetheless, we have some challenges before us. So I want to just tell you, the very first episode that we did in January of this year, I did sit down with Larry Levitt, Vice President for Health Policy at KFF. And I also was joined by Edwin Park. And if you recall, Edwin is a research professor at the Georgetown University Center for Children and Families. Now, I do encourage you to go back and listen to that one, because the entire conversation, well, we might as well have had a crystal ball, because it focused on the what ifs with respect to the ACA, Medicaid cuts, which, as it turns out, of course, was quite foretelling given where we are at this point. Okay, so again, things might have changed, but we can be sure that 2026 is going to have far more health challenges ahead just by the way things are going right now. So all these unprecedented policy shifts, we're going to have one more conversation about rural health. And I do hope that you will stay with us and listen to this conversation, because I am joined by two guests today, both of them offering outstanding information and very unique perspectives about policy shifts and their impact on rural serving community health centers. Now, you may also know them as federally qualified health clinics, or FQHCs. So first, you're going to hear my conversation with the very engaging Dr. Feygele Jacobs. Great to have her here. And Feygele Jacobs is the director of the Geiger Gibson Program in Community Health and professor of health policy and management at Milken Institute of Public Health. And from there, you're going to hear my conversation with Mr. Joe Dunn. And Joe is the chief policy officer at the National Association of Community Health Centers. And when you listen to the very end, you're going to hear something from Joe that is it's really as insightful as it gets, because he talks about effective strategies for successful advocacy efforts with your member of Congress and those serving you at the state level. I'm not going to give this one away. I really want you to listen to his very sage advice about how we can be effective advocates for equitable healthcare in rural America. Again, I am so excited that you've made the choice to join us. I know you are ready to get going, so you're going to say it with me. Are you ready? I am, so let's just go. Dr. Feygele Jacobs, welcome to the Rural Impact. We are so pleased, and I mean it sincerely, to have you here for this critically important conversation. Welcome.
Hi, very nice to be here. Thanks for inviting me.
It is my pleasure. Okay, well, everyone who listens to this podcast knows that we are working to connect the dots between policy and rural quality of life. And Dr. Jacobs, especially after the signing of HR 1, Of course, we all knew it before as the one big, beautiful bill. We've been having many conversations on this podcast about the implications and the impact that this legislation is having on rural health systems. And the bulk of those conversations have really been focused on the plight of rural hospitals, which is important, but they are not the only health safety net, as they are called, in need of a lifeline, as I see it, because we also know that community health centers, also known as federally qualified health centers, are bracing for an impact that I can just say in all the years I've been doing this, I don't think anyone saw coming. So, and maybe you all didn't either, because in early of November of this year, you were one of several authors of a policy brief that I found titled "Widening Holes in the Safety Net, Community Health Centers Are at Risk." So before we dive into your findings, because I want to hear all about it, let's not assume our listeners understand what these health centers do and who they serve. So let's start there.
Great. So thank you so much for that great introduction, Michelle. Community health centers. Community health centers occupy a really unique place in the American healthcare landscape. And the very first community health centers in the country were actually launched as a small demonstration program. They were part of President Lyndon Baines Johnson's Office of Economic Opportunity. And their roots really go back both to the civil rights movement and the war on poverty. And since their earliest days back in the 60s, health centers have been critical access points for primary care. They operate as nonprofit organizations. They're governed by their communities, and they're really designed specifically to serve entire communities and to think of community health issues from a broader perspective. So by mission and law, they address the healthcare needs of people who are low income, of people who live in medically underserved communities, and often of especially vulnerable populations, people who may be experiencing homelessness, or people who are agricultural workers or seasonal workers, or people who live in public housing. So this all started with just two health centers, one rural, one urban, in 1965.
Wow.
And so, two small locations, and there's really a, fantastic story and history behind that. But what I'd really like to convey for our listeners here today is what's happened in the intervening years is that those two health centers have resulted in a movement. And health centers have really flourished in a way that few people would imagine. So today, there are about 1,400 health center organizations, and they're operating more than 10 times as many service sites or locations. So there are more than 16,000 access points where people can get care through a health center. And throughout that history, health centers have stayed true to their core mission, and that is to provide a healthcare home to everyone, irrespective of whether they have insurance, regardless of their ability to pay, and to work in communities that otherwise would have limited access to care. So when you look at who's served today, it's about 33 million people, nearly 90% of whom live in households whose incomes are under 200% of the federal poverty level. That's pretty low income.
Right.
Nearly 50% of those people are covered by the Medicaid program. More than 18% have no insurance. And so, so to put it a different way, when you think about it from a population perspective, it's 1 in 10 people in the United States, 1 in 8 children, more than 1 in 15 people who are age 65 or older, 1 in 5 people who live in rural communities, about 500,000 veterans. So really, a diverse group of people all across the country, in urban areas, frontier areas, rural areas. I used to joke with my kids when they were young adults driving across the country from one part of the country to the other. I live in New York City. My younger son at the time was living in Oregon, in his state on the West Coast. And I used to say, if your car breaks down, find the health center. They may not know me, but they'll know that you're part of the community, that you sought out a health center, and someone will find a way to help you.
Oh
And
my
it was sort
gosh.
of a joke, but sort of not, right?
It's not. It's not, because as I think about this in my mind, I'm thinking, okay, you talk about all the locations, access points for care, how many patients are served. It also makes up a very large portion of our health workforce.
Absolutely. And I think that one of the things that health centers are known for, going back to the very earliest days, is providing really good work and job opportunities and career development opportunities for people who live in those local communities.
Mm-hmm.
So they're not just providing healthcare services, they're really an economic development engine as well. My colleague Leighton Koo, who's an expert in that area, has done a lot of work in the area, not only of how the healthcare workforce, supports the economy, but what some of the changes under HR1 are going to mean for the economy, not only at the federal level, but at the state and local level, and in terms of job loss, not only health centers, but the broader healthcare system. And it's really stunning. It's really stunning.
And it's been very challenging for many folks that I talk to, not on this podcast, just in general. I think because it feels so intangible right now that people are like, well, things always tend to work out. Well, in this particular case, I mean, we are like teetering on the edge. I want to kind of go here because we are recording this conversation on December 4th. And as of today, it seems all but certain, maybe to others, maybe not, that the Affordable Care Act enhanced premium tax credits will expire at the end of this month. And as a result, this is not, hyperbole here, millions of patients will likely lose their health insurance marketplace coverage. We know that premiums are going to skyrocket. Health centers, they're going to have major losses in 2026, which is just a month away. What does that look like? Like in terms of some hard numbers, if you can, what will FQHCs do based on the findings of your report? Maybe tee up your report a little bit so that folks can have some context.
Sure. And I really appreciate that question. And then if there's time, Michelle, I'd love to come back to premium tax credits.
Yes.
But let me, try to address specifically this issue. And you're absolutely right. Every day we wake up and we sort of hold our breaths, to look at the healthcare news aggregators, right? Mm-hmm. And of course, today, more articles saying, well, 3 weeks to go, not clear what's going to happen. So just to sort of frame where health centers were before we got to this year, since the introduction of the Affordable Care Act, we've seen enormous growth in health centers. They've grown over time, as I mentioned, since 1965. But really, a huge share of that growth has happened just in the past, 10 or 12 years. In 2013, just before the ACA really took effect, health centers were serving about 21 million people. And as I mentioned earlier, today, or in 2024, so let me just say that the latest data that are available, that are universal data for the health center program, are for 2024. So in 2024, they were serving more than 33 million people. So that's a growth of more than 30% in just that short period of time. And what we discuss in that report that you mentioned is that growth continued, and it continued even through the pandemic. But now health centers are really under pressure. And while their volume has increased financially, they haven't done nearly as well. So it's important to understand that health centers, receive their funding from multiple sources. There are insurance payments, there are grants from the Bureau of Primary Health Care, part of HRSA, provide core funding for infrastructure and help support care for the uninsured. And they are extremely important and part of the bigger funding bill issue. But Medicaid is really the largest source of health center revenue. And so what we've seen is that even just between 2023 and 2024, health center revenue increased, but it increased at a lower rate than in prior years. And meanwhile, costs and expenses continued to climb. So when you look at what we call operating margins, which is basically, your revenue less your cost, we saw that operating margins have dropped. In 2020, there was a positive margin. It wasn't a huge margin. It was 1.4 billion, but that was about 4%. But by 2024, health centers were operating in the red. And the situation had almost totally reversed with total losses of about $1.1 billion.
Wow.
Which is a margin of negative 2%, right? And so as these policy changes in HR1 take effect, the conditions are likely to worsen, making it even more difficult for health centers to, remain sustainable. And of course, 2025, some of this has already begun. So we don't yet have that 2025 data, but this could have already occurred. So why is this happening?
Yeah, that's a great question, because I'm going to ask you, why this and now this?
Yeah. So let me see if I can help sort of shed some light on that. So one thing is that during the pandemic, we had what was called continuous Medicaid eligibility. People did not have to recertify to continue to get their Medicaid coverage, and that would have been the normal practice. Mm-hmm. But when the public health emergency ended, that provision went back to its prior status, meaning people had to demonstrate that they remained eligible. And what you need to keep in mind here is that often people remain eligible from an income point of view or from a health status point of view. But because of the huge administrative challenge of, getting your documents together, submitting them, figuring out how to use the systems, many people lose coverage just for those administrative reasons. And, for anyone who's ever had to navigate any type of healthcare coverage, whether it's public or private, that is something that I think will really, resonate for you.
Yes.
So Medicaid began to unwind, as we call it, and Medicaid became a smaller share of patient revenue. By 2024, average Medicaid enrollment had declined. But one of the things that we know is, you continue to need healthcare, whether you have coverage or not, right? Now, some people choose to forego their care, but often people will continue their care and they seek care when they need it, where they can get it, even if they have no coverage. And because health centers serve everybody, irrespective of their ability to pay, they will care for uninsured people on a sliding fee scale basis. Well, that brings in a lot less revenue than regular Medicaid payments, right? So that was one issue. Second issue was that during COVID, there were supplemental grants that were provided to healthcare providers, including health centers, but those ran out. The fund balances were depleted. That pandemic period ended, and those supplemental monies ended. And then finally, those core grants that come through HRSA were essentially flat. Even though demand for care was increasing, the grant amounts really have been relatively flat, and they haven't kept up with inflation. So what you see is that by 2024, in the majority of states, health centers had some net losses. In, I think it was 7 states, I have to stop and now try to remember them. Those losses exceeded 10%. And many of those, I know this is the Rural Impact Podcast. Many of those were states with, large rural population.
Oh, yes.
Vermont, Texas, Wyoming, Minnesota, Arizona, right? So, what you're seeing is losses. And again, the situation may have, deteriorated even further. We are in this period where there's health center funding now, has been temporarily extended through the funding bill through July. But what the longer term funding prospects are for fiscal 26 hasn't yet been determined. And so when you have uncertainty about your funding, that also creates pressures, right? And that's the situation that we really find ourselves in today.
Yeah. I read something this morning. I wake up and I start reading all sorts of, that's just my nature, health policy things, but rural policy in particular. And I read a piece today, and I don't remember the author, but the analogy was that we treat healthcare like day trading instead of long-term investing. And so, at the end of the day, you said it, folks still need healthcare. And what I really see happening here is something the trend is that we're going to have more people who are sicker, and because they are foregoing their care, they'll seek care in more expensive venues like an emergency department and so forth. It's just a mess is all I can say. Mm-hmm. Let's transition over to something here, because in the paper you talk about some of the immediate and future risks, and you would have to be, I'm sorry, folks, you may be mad at me for saying that, living under a rock, not to understand the next thing I'm going to say, which is the restrictions on care for immigrants, whether they are here. I mean, people who have come here, they've gone through the process, they are here for, they've got their papers, as they say. But regardless of whether or not you have that status, we know that community health centers are, they care a great deal for immigrant populations. Now we've got these restrictions. Talk a little bit about that.
Sure. So first, let me say two things. One is I love your day trader analogy, and the second is I am the U.S. born citizen child of parents who were refugees. So for me, this whole question about immigration and how we treat immigrants, I can't say enough how important that feels to me, even being born here and even at my age and even with the work I do. So because health centers serve poorer communities, whether they're urban or rural, they're more likely to serve immigrant families. And that includes people like myself, U.S. citizen children who were born in the U.S. to parents who were immigrants. Now, in keeping with both their mission and their statutory obligations, health centers don't collect information on immigration or citizenship status. Excuse me, I stammered over that. But we know, given the communities that health centers are in, that a large number of people getting their care at health centers are immigrants. But recent policy changes, as you said, have hindered immigrants' access to care. So there are a couple of things. One is that in the OBBBA, there were changes in immigrant eligibility for both Medicaid and marketplace health plans. So certain categories of immigrants, only certain categories of immigrants remain eligible, but other categories, like people who were refugees or asylees, lose their Medicaid coverage. So that's one of the things that's happening. Now, in July, several federal agencies, including HHS, issued a notice that reinterpreted a longstanding policy called PRORA, which stands for the Personal Responsibility and Work Opportunity Reconciliation Act. That's a mouthful. Mm-hmm. And that's a U.S. law that governs eligibility for benefits. And what they did with this notice is they significantly expanded the definition of what's a federal public benefit. And they declared that community health centers and many other types of programs, including things like Head Start, which, by the way, got their start in 1965 in the very same set of Office of Economic Opportunity programs as a health center program. But what that notice ruled was that these programs could no longer serve people who were undocumented or what are called other non-qualified immigrants. Now, that's contrary to the statute that governs community health centers, but the policy was meant to be effective immediately upon publication. It was challenged in the courts, and in response to lawsuits, there was an injunction, so enforcement was temporarily paused. Mm-hmm. So the ultimate legal outcome is unresolved, but that's sort of the backdrop to all of this. Now, more recently, there was a separate but related notice of a proposed rule on something called public charge, which is an immigration policy that's intended to determine whether an immigrant is likely to depend on the government for their subsistence. And if it's determined that that's the case, they would be inadmissible to the U.S. So putting aside the fact that there's been an injunction on per vora, you can imagine that this creates widespread fear in communities, including among people who are here legally, right? Or people who have what we call mixed status families. Maybe the children are U.S. born citizens, but mom or grandma is not. So as a result, they avoid seeking health care. They avoid going to care. That's what we call the chilling effect. And so, these kinds of policies and proposed policies are especially harmful for programs like health centers. They're especially harmful for health centers that may serve, for example, agricultural workers. I mentioned that there's a group of health centers that specifically serve agricultural workers.
Right.
And so, these policies don't change the funding levels for health centers directly, but what they do is they affect the access for people who historically have been able to get care. So this whole immigration issue, as you said, you would have to be living under a rock,
yes,
to not be aware of it, and huge implications, for our communities.
Yeah, the punitive nature, and I think about these are organizations whose whole charge is to provide essential and vital health services, and now they face punishment, fines, and whatnot for doing that or withholding. Let's talk about another one. There's a few more before we kind of close out here. I want to talk a little bit about the Medicaid coverage for family planning. This one, I just don't understand how these are not like screaming headlines for folks, because now we've got restrictions on how folks can access just things as simple as family planning. Let's talk about the provisions in this law where this is concerned.
Okay. Wow. So this is another one where you just got to go, what is happening here, right? And again, full disclosure, decades ago, I started my career working in Planned Parenthood. So HR 1, I think I used the acronym OBBBA without saying, one big beautiful bill act.
Yeah. I think folks know it by now.
Yeah. It's a horrible acronym. It doesn't really roll off the tongue. So what HR 1 did with respect to family planning is it banned Medicaid funding from any organization that provided reproductive health and abortion services that earned, more than a threshold amount per year from Medicaid. Now, it's important to understand that Planned Parenthood already could not accept Medicaid for abortion services because of the Hyde Amendment that prohibits federal funding from being used for abortion. But what this does is it really is a direct attack on all other services that Planned Parenthood provides. And many young people will know that Planned Parenthood does way more than just abortion. They provide well woman care and contraception and cancer screenings and screening for, sexually transmitted infections and so on. Now, this week, a federal judge has again blocked a provision that stripped federal Medicaid funding from Planned Parenthood affiliates. So there's again, sort of a temporary lull, but we know that already a number of Planned Parenthood centers have closed. We've been reading that in the media. And this goes back to the summer, when an appeals court had let the rule take effect. So what does this mean for health centers? Well, first of all, health centers don't offer abortion services, but they do provide women and their families with well woman care, with prenatal and perinatal care, with family planning. And in some states, more than 30% of all women of reproductive age may receive their health care at a health center. Last year, more than 8 million women in their childbearing years relied on health centers for care. So that's about 1 in 8 women in America, between the teenage years and let's say 45, right? And in 2024 alone, those women made about 6 million visits to health centers for reproductive health care services. So when Planned Parenthood is attacked, when Planned Parenthood can no longer provide these vital services, there are a few places that women can turn and that families can turn. They turn to health centers, which on the one hand, it's great that the health centers are there, but it means that there's more demand for care. And that demand is coming at a time when health centers are already being stressed by all of these other things that we've talked about that are really affecting their bottom line.
Yeah, absolutely. And I'm going to say, I've never shared this with our audience, but Planned Parenthood, that's where I received all my prenatal care when I had my first child, who now is 40. And so back then, it was the only place I could go to be able to afford because I was working, but uninsured. And they received me. So yes, a shout out because, ignorance is bliss, as they say. And there's a narrative out there that just is, it's just frankly not true about what it is that they do. Okay, so let's talk about one other major roadblock to care, which are the Medicaid work requirements. I know that there are a lot of health organizations out there that have had to literally hire a person, so expend more dollars on hiring a person to help patients navigate work requirements. I see this as being just another pile-on strain for community health centers. What kind of share with us what you foresee the landscape being when all of these things start kicking in? And the clock is ticking. It's happening soon.
The clock is really ticking. So what HR 1 did is it made substantial changes to Medicaid law. It shortened renewal periods. It added a lot of administrative barriers. It, shifts the burden to the states, and it restricts how states finance their share of costs and how they pay providers. But finally, it has imposed these mandatory new work requirements. And beginning in January 2027, states must require that Medicaid enrollees, adult Medicaid enrollees between the ages of 19 and 64, meet what are called work or community engagement requirements. They must demonstrate that they are engaged in that work or community engagement for at least 20 hours a week, 80 hours a month, unless they're exempt. Now, I mentioned earlier that a lot of this is about administrative burden. We've done a number of other studies with different colleagues that show that, this myth that the people who are on Medicaid who aren't working are, young men sitting around playing video games, and nothing could be further than the truth. Mm-hmm. I'm sure there's, maybe someone knows one example of that, but that's really not who are not working. And what some of our colleagues have found is that who's not working are largely women who are somewhat older, in their 50s and 60s. They've left the workforce to care for family members. Maybe it's a grandchild, maybe it's an unwell spouse, right? But it's not, young, and they may not yet have a particular health condition, but they're aging, right? So they have all of the normal issues related with aging. And of course, these documentation requirements are really prohibitive. So our team worked with colleagues at an organization called Capital Link to analyze what this will mean for health center patients. And what we've estimated is that about 5.6 million community health center patients could lose coverage because of mandatory Medicaid work requirements. And I'm sure people have seen many estimates of, sort of the broader workforce loss and what that looks like. We think that it's going to disproportionately hit community health center patients because of who they are, right? Because of their income levels, because of where they live, because of their extreme poverty. And so that loss of about coverage by about 5.6 million people could lead to losses of about $32 billion in health center revenue. Yeah. And by the way, we talked for a second about enhanced premium tax credits. Similarly, we have looked at what's the impact on health center patients of those tax credits disappearing? And we've estimated very conservatively that about 2 million patients could lose their marketplace coverage. And here, the losses are going to be particularly serious in states that didn't expand Medicaid, where more people get their coverage from the marketplace. And we've estimated that it could be a shortfall of nearly $10 billion for health centers. So you've got, on the one hand, Medicaid, on the other hand, marketplace plans, which have filled an extremely important role, especially in those states that did not expand Medicaid for working age people. So it's like a double whammy.
Right. And I have so many other questions. I wish we had so much time because I'm thinking about the Medicaid work requirements, and we've talked about it on this show. For rural, it's different. There are challenges that are inherent to rural. So we talk about, I just thought about this over the weekend, folks. Tyson announced the closure of a gigantic meat processing plant in Lexington, Nebraska. I've been there. There's a critical access hospital there. Think about how many employees now will find themselves come January, over 1,000 unemployed. And when we talk about transportation barriers and so forth, so it's not an unwillingness to work. It is truly the circumstances that prohibit folks from being gainfully employed. And sometimes you are employed for 3 jobs and you still don't have a place to go. Oh my gosh. All right. So I'm going to go. Here's my closer for you. Your policy brief. And I'm going to put the links of the policy brief on our website, theruralimpact.com. But it concludes that the Congressional Budget Office, CBO, has confirmed that health centers are cost effective and increasing mandatory CHC funding levels could lower overall federal Medicaid and Medicare costs. Isn't that what we're supposed to be doing? Right? Isn't that the whole ruse here, that we're supposed to be saving ourselves? That said, how do you foresee community health centers surviving given the circumstances they are in today? What do our listeners need to understand about that?
Well, I wish we had another hour, Michelle,
Me too.
because, you've raised so many really interesting points. And of course, hearing about this, the plant that's closing, we're hearing that again and again and again, especially in rural communities.
That's where they are,
et cetera. It's quite horrible. And you're right. There's all this evidence that shows that high quality primary care at health centers helps reduce the need for more expensive care. There was a recent study by some of our colleagues that showed that even though Medicaid patients who live in really isolated neighborhoods are less likely to have a primary care visit, if they get care, it's at a community health center, right? But as you've just laid out, healthcare policy is at an inflection point. There's enormous pressure. You've got these, headwinds, shifting, and what's happening is that the entire system is really contracting. So, I don't want to be a Pollyanna, but I guess I want to say that health centers are known to be highly innovative. They're known to be highly agile, and they've faced a lot of change before. None perhaps so extreme as now, but for anyone who lived through the Reagan administration, block grants, we know health centers have come through hard times. And I think that over those times, they have demonstrated that, there are a lot of things they can do. But given these policy changes, they can't indefinitely sustain losses with funding uncertainty and policy changes. So I think that the coming months will, really be telling about how health centers can strategically uphold their mission. I think they will be at the forefront of new approaches to thinking about how do you preserve care. You mentioned navigators. Navigators have been part of health center programs forever.
Yes.
One of the things that health centers do under the law is they provide what are called enabling services like transportation and navigation and translation to help people get access. So that kind of thing is embedded, but I think that there's, really the need for more of that. And I think health centers are going to have to really look, on the one hand, to how do they help their patients keep their coverage, right? First and foremost. And that's something that part of our team is working on right now. on the one hand, so we want to make sure people keep their coverage. And on the other hand, we need to look at how do we really stretch limited resources. Maybe that's through partnerships or technology. So one thing to know about health centers is that they have strong membership organizations at the national level, but also at the state level. These are called primary care associations or health center controlled networks. And that network model, I think, becomes really important here because it gives some infrastructure basis for health centers to think about how can they maybe adopt more efficiencies. Are there places where they could consolidate or operate more effectively? And I think that that's going to be the name of the game.
Yeah.
But first and foremost, I think health centers are here to stay. This is our lifeblood, right? This is what we do. We care for people who are under-resourced. We care for entire communities. We provide much more than just medical care in health centers. And I think that's going to continue. And I think, we are looking for, ways that health centers can be more resourceful. And, in my role, which is now moved into an academic and a research and a support role rather than where I spent most of my career, more out in directly consumer facing organizations or working with more directly with those organizations. What I can say is I think health centers are, they're in it to win it on behalf of their patients. That's what they're there for, on behalf of their communities.
Yeah, that's wonderful. Oh my gosh. Well, you actually gave me a great segue because we are going to, after a quick break, we are going to hear from Joe Dunn. And Joe is the Chief Policy Officer at the National Association of Community Health Centers. So we're going to talk a lot about policy on the other side of this. But for now, Feygele Jacobs, I cannot tell you what a pleasure it was to meet you. You are welcome back anytime. Listen, any research that you've got that affects rural, you know who to call. Now you've got a phone. I've got a phone in front of you and you've got one in me.
Great. I hope to come back, and I really appreciate the invitation and the opportunity to talk with you, Michelle. Thank you so much.
Thank you to you. Everyone stick around. As I said, we've got another guest coming up on this episode of The Rural Impact. We'll see you in just a few minutes.
What's the first thing that comes to mind when you hear rural? Is it agriculture, recreation, country, or maybe even elections? Rural can't be defined by one word, one place, or one population. However, we can connect the dots between rural quality of life and policy. And that's what the Rural Impact is on a mission to do. If your organization advocates for rural policies that contribute to thriving rural communities, we invite you to join our partner network. By joining us, you can tap into a wealth of resources, expertise, and a network of like-minded organizations. Discover how we can help you expand your rural reach and share your impact. Visit theruralimpact.com to connect with us. That's theruralimpact.com.
Well, as promised, we are back because we have a second part of this conversation that we're talking about today, community health centers, and really the plight of where they are today and what we're foreseeing might be the case in 2026. And to help us with this conversation, I am very happy to welcome Joe Dunn, Chief Policy Officer at the National Association of Community Health Centers. Joe, it's really good to have you here. Welcome to the Rural Impact.
Thank you so much for the opportunity, Michelle. Really looking forward to the conversation.
Thank you so much. Joe, my listeners know, and they heard someone that Dr. Feygele Jacobs, we had on earlier. We know that this is we're talking about it because it cannot be said enough. And quite frankly, I don't think there's just enough headlines. Mainstream media certainly isn't talking about it. I know they've got their plates full with other distractions, but at the end of the day, as we heard from Dr. Feygele Jacobs, she covered a policy brief focused on the widening holes in safety net with a focus on the finances. And I know we're going to talk about that as well with you. But first, you all published your own report that was brought to my attention that goes really deep into the many ways in which community health centers are lifelines. I mean, really, truly lifelines for rural populations. So your piece the report is called Community Health Centers and Rural Health, Essential Access, Enduring Challenges. And I think enduring challenges is a very generous understatement. Our listeners are hearing this conversation at the end of 2025. It's our last episode of the year. And it also marks the 60th anniversary of community health centers. So let's start there. From your perspective, Joe, what do our listeners need to know, understand about the contributions of community health centers in the rural space for the past 6 decades.
Yeah, so I really appreciate the opportunity to come and talk to you about this. This is so critical. And as you mentioned, for generations, health centers have been meeting the needs of their communities. And this is one of the models that really works well in rural communities, right? Providing that comprehensive primary care that includes medical, dental, behavioral health, pharmacy, enabling services like transportation, all under one roof are very integral to the success of a community. And the way I always think about this is if you're in a rural or small town area of the country, having primary care is essential to attracting that economic development, right? That factory, the processing plant, the local provider, base. So it is just central. So as we think of, this environment where unfortunately too many rural hospitals have closed, really rural health centers have stepped up. Health centers are 40% of health centers are in rural communities, and they are facing really significant challenges, either through the funding instability, the workforce challenges, aging facilities, some of those things that are out there. But really what's central to us is we try to work every day to help the health center patients and the organizations meet the needs of the community. And we've had such success over the last 60 years.
Yeah, don't I know? As we were talking with Dr. Jacobs, I mean, just the totality, the impact that community health centers make, and some of the things that you mentioned, she did as well. And of course, we know that there has been a great deal of focus this year on MAHA, Make America Healthy Again. And I say kind of on the side of my mouth, I wonder what the before time was. But community health centers have consistently shown, even though the budget office says it as well, that you've got a commitment to clinical quality excellence. You guys are working on chronic disease management, prenatal care, and so much more. So talk to us a little bit more about what data can you share about how community health centers really have always been focused on healthy outcomes for patients they serve. The goal isn't to just treat sick people. Really, I see community health centers as at the forefront of that preventative care that is so underrated, I think, because it's not as tangible as dollars for treating somebody who might have an illness.
Yeah. And, we completely agree with the focus around reducing the chronic disease burden and treating and preventing that. And health centers are, going to be central and vital to that. So, chronic diseases are a leading cause of poor health outcomes and higher healthcare costs. And, really leads to people going to seek care at an emergency department rather than, at the front end, getting that care at a primary care setting like a health center. And, it's really one of these things where, especially in rural communities where there's a higher and heavier chronic disease burden, particularly in cardiovascular and behavioral health. But, the good news is that health centers report higher rates of hypertension and heart disease, mental health conditions, but often will exceed the national averages on these conditions and the outcomes that they have through the comprehensiveness of the care that is provided. And so, the good news is we know there's a model that works, and we would love to have that expanded into other communities. You mentioned one of the reports that we did a few years ago. We did another one that really highlighted that 100 million Americans across the country lack access to primary care. And most of those, as we looked at the map, were in rural and small town America, right? And so we think of, policy solutions. Here's a real proof of concept of something that works. There's data behind it. As you mentioned, the Congressional Budget Office has recognized this as investments in health centers will lead to better health outcomes and lower costs downstream through reduced utilization of emergency departments and hospitals. And so this is something that we are really committed to working with the current administration, with the Congress. Health centers have always been nonpartisan, but have enjoyed bipartisan support. And especially in rural communities where they are often the only healthcare provider in town. We need them to be supported. And luckily, we've had that tremendous support from the Congress across the board.
Well, that is good to hear, because the next topic I want to talk to you about is the Rural Health Transformation Fund. I mean, we know what it is for our listeners. They've been tuning in. They understand what it is. How have community health centers participated with their states? What are some of the aspects? Because it's a $50 billion in taxpayer investment. And I know many people who were involved with devising their own state applications and plans. It was a exhaustive body of work in a very short period of time. So again, how have community health centers participated? What has your input been? What are some of the asks? And from there, what are some of the expectations you have once the money starts flowing? The first half of that the 50 billion is the 25 billion that we can expect to start to see. I don't know the date. Maybe you do.
Yeah, so the applications were due a little while ago, earlier, or actually last month now. But decisions will be made by the end of this year, and money would be available starting next year. So maybe to zoom out, we were really pushing and advocating for health centers to be included as part of this. A lot of the media attention and, the focus had been about rural hospitals. And while rural hospitals are critical parts of the rural healthcare system, you can't forget about health centers. As I mentioned, a lot of them are the only provider in their communities. And so we wanted to make sure that that was an option. And we were successful in getting the legislation adjusted and to make sure that it was happening. So as the states were really in this compressed time frame from July to November, as they were developing their applications, a lot of them looked to community health centers, the state associations, which we call primary care associations, to try to harness what is out there and what the capability could be to really prop up and support the rural healthcare system. So, examples around this, a lot around technology. A number of states are looking at technology advancements. So things like remote patient monitoring or other kind of things that often are out of reach for health centers, right? They are very high touch in terms of high and trusted providers, but maybe not always high tech because of some of the challenges financially that I know many of them are facing. And so something like ambient AI or artificial intelligence. So a scribe that is, rather than a person, but, kind of a technology platform that could be useful in helping the physician or clinician, categorize notes or make suggestions or, help with clinical decision making. Those are all things that some are thinking about, along with, a number of them are looking at workforce and other kinds of approaches. So it varies from one state to the next. But I think what we've been really encouraged by is so many of the states look to health centers as key partners throughout this to really make sure that the money is spent in the most efficient and impactful way, given the core issues facing rural America, but also, the value of federal investments. We don't want to have anything squandered.
Absolutely. And you don't. I mean, it's like the most lean, nimble organizations you will find operating on razor thin margins. It's not about profit. Let's talk a little bit about some of the policy challenges, because we do work to connect the dots between policy and rural quality of life. I mean, great. We've got this fund. We can look forward to seeing innovation and whatnot. But at the same time, we've got headwinds in other areas, including severe workforce shortages. And Joe, I've been thinking about the news that came out last week about professional degrees and how it is really targeting like nursing degrees and so forth. Community health centers rely heavily on nurses and not just physicians, of course, but there's a whole other world out there of those who are providing care. What is the policy stance? Or, what are some of the things that you all are doing to help alleviate the ever-growing challenges of severe workforce shortages? I mean, we are not Chicken Little, like the sky is falling. This is a real thing happening.
Yeah, and it's so critical. We, as all health centers, they employ about 330,000 full-time employees. About a third of those are 93,000 healthcare professionals in rural communities. And you're exactly right. That includes physicians, nurse practitioners, dentists, behavioral health providers, case managers, frontline staff. So it really is a whole team effort. And that, I think, is a differentiating factor compared to maybe a private practice physician, right? That may just have the physician and one, or two support staff, right? This is a whole team. And so when you go to a health center, you're going for a number of different things. And that one-stop shop, and especially, I think it's important around behavioral health, right? And we think of the stigma associated with behavioral health, and especially in a rural community where you may know all of your neighbors, seeing that red truck at the health center versus seeing it at a mental health provider only, right? That's going to be different because that person may be there for any number of things, right? So, we support a number of different workforce initiatives. One of them that has been so critically important is the National Service Corps. So this is a program that's been around for, I think it's 50 something years, where it really has been impactful in placing individuals in rural and underserved communities, through a loan repayment or a scholarship approach, where they are able to reduce some of their, educational costs because of the commitment that they give to rural and underserved communities. And it has been so successful. It's really kind of the backbone of, the workforce initiatives that the country has around this, especially in rural. And so we are supporting increased funding for that. There's another one called the Teaching Health Center Graduate Medical Education Program, which is really flipping the education of physicians on its head. So providing residencies that are more community-based at a health center or another community provider, rather than just having it at a hospital. And the difference there is that if you expose people, especially in a rural community, to this type of setting, a lot of them want to stay there. But the challenge in rural in particular is if you don't necessarily grow up in that area, you may be unfamiliar or, skeptical about, can I fit in? Can maybe a spouse, find a job? Is there something for me to do? Is it going to be enough, educational for, maybe a family? That's where through this program, the Teaching Health Center program, they're able to expose people early on in their career. And that really leads to better outcomes, better care, and actually much more focus around primary care, which the nation as a whole needs desperately.
Yeah. And sensitive to the culture, the communities, because it's not, you go to the West Coast, to the East Coast, South, North. I mean, it all looks different. And having individuals within your community interested in staying, isn't that what we want, And plus they're trusted and community trust people they know. Let's talk a little bit about the funding instability and with that, the aging facilities and infrastructure. Because the Rural Health Transformation Fund, as I understand it, there's no money in that for facilities, capital improvements and that nature. And I think about aging facilities really from a hospital's perspective, because I've been working on them for so many hospital replacements and so forth for many years. What are some of the challenges that there's an intersection to policy where funding instability, of course, reimbursements, and aging facilities and infrastructure is something that we could all maybe not understand completely, but when infrastructure is not invested in, you'll know it.
Yeah. No, it's such a great point because, many of these areas or facilities are, older. One of the things in rural in particular is we've been very supportive of mobile healthcare, right?
Yes.
So not necessarily that you need a brick and mortar facility in every community, but maybe through a mobile van or, some other type of arrangement where, you can provide care to a community in a number of different ways. But I think what you're really driving at is, some of the challenges that we see in Washington right now. So the bulk of health center funding comes through an account and a pathway that was originally started in 2010. It's now about 70% of the funding. The idea behind this initially was it was going to be multi-year funding that you could count on, that the health centers could plan around, that they knew there was going to be a growth and investment strategies that they can bank on. The difficulty that we've seen over the last couple of years is that has not been the case. It's been much more piecemeal. So right now, you may, like with the government shutdown that just occurred, we actually had a lapse in funding. Luckily, They were still able to draw down the money, but that was only for a temporary period of time. But the issue is we're on the 7th now short-term extension of this funding. Now it goes through the end of January. We are constantly trying to educate members of Congress about the challenges that presents, right? That the difficulty to plan ahead and to know, can I make investments? Can I look at maybe retrofitting a facility with other dollars? Because there are some other limitations within that pot of money for facilities. And so, this is just something that we always are kind of thinking of. We believe that when you go into any health center, that it should reflect the best care. We want health centers to be the employer, provider, and partner of choice in their communities. And so part of that is the look and the feel of the organization. And sometimes, changes need to be made. It's just difficult given the financial challenges.
Yeah, and it's not about aesthetics, folks. It really is about ensuring that there is an environment that is the highest provides the best opportunity to provide high quality clinical care. I want to talk a little bit about geographic isolation and transportation barriers. Unlike critical access hospitals, community health centers do look to find transportation solutions and mobility solutions. Our listeners know that we just did a podcast, a live stream about my time in rural Massachusetts and driving the entire state with somebody in 2 days and really getting a firsthand look at how challenging it is to get from point A to point B because it could be 75 miles apart. So talk about where policies can help to close the barriers of transportation that are born just strictly out of geographic isolation.
Yeah. So this has been something, I think, especially post-pandemic, where around telehealth policy, there's really been a broad bipartisan support. And that's one mechanism that I think could solve some of these challenges. Certainly, you need to be seen in person for a lot of things, but especially maybe around mental health. We've seen a lot of telemental health or telebehavioral health that has been very impactful. That's another issue, though, that has been kind of had this short-term extension and actually lapsed also during the government shutdown. But, we really think that technology plays a significant role for care. But, we also know that many rural areas lack reliable high-speed internet or cell coverage, and that makes it a challenge. But, I reflect back on one of the health centers I've had the fortune to visit was in Alaska. It was a community in Bethel, Alaska, off the road system. Internet was the number one issue that they faced. And it was so interesting. This was a health center, again, off the road system. They pointed outside to me, they had two mobile approaches. One was a boat for the summer when the river was open, and there were two snow machines. And those were to really get towards remote native communities that needed care and, provided them year-round access to these communities. But that's an example of some of the challenges that these rural health centers face, but also the ingenuity that they have to really think about, okay, how do we meet the needs of our patients and how do we get there? So it's something that is always awe-inspiring as to how they figure it out. I'm also thinking back now, a health center that we work with really closely in South Dakota. They have facilities in towns of like 300 or 400 people. That's if that health center wasn't there, there's not going to be anybody else, right? And there's no one coming in. So that's why the policies need to be supportive of them, provide the funding, and then, other things like telehealth to provide that full wraparound service.
Yeah, I love that. I love the Alaska. I mean, I worked at Wrangell, Alaska. So I mean, it is as remote as it gets, although there's a lot of remote places here as well. And to your point, I mean, it's one thing to say we're going to have policy that says we have to, have provisions to help make our communities healthy. But then when you put up roadblocks in other places, it's like that game of whack-a-mole, the vision I have. All right, Joe, before I let you go, I always like to ask our guests who are in your position, advocacy works. Advocacy in volume, more voices, the better. So what is an advocacy tool or idea that you can share with our listeners that they can take away today and potentially put into action tomorrow that is going to help to make sure that policy shifts, because we got a lot of shift happening, policy shifts are in favor to ensure that community health centers not only survive, because that's not the point. For communities to thrive, community health centers, rural health providers have to thrive as well. So what are some of the advocacy tools that you all are recommending to your, I don't know how many members you have, but I know it's a lot. I've been to your conference. It's a sea of really committed people. What can we be doing right now? I know people are busy for the holidays. When this drops, it's just before Christmas, but this work can't stop.
Yeah, the advocacy is so critical. And the reason why health centers have grown to serve at least 34 million patients annually and up to 52 million over a 3-year period and be that comprehensive is because of the work of others over the decades, right? That advocacy that they had. So this is the lifeblood. And we really believe that grassroots power, grass tops power that people have in their communities. So in terms of specific steps, we always recommend, go in and meet with your member of Congress or their congressional staff. I'm a former Hill staffer myself. I worked there for 11 years. I know the power of when somebody takes time out of their day or invites somebody to, the facility or, to talk about an issue. I know how powerful that can be and to change the minds, right? And so that's one part of it. How you can do that, we have tools on our website. We also have, so like a toolkit as to how you could go about that. How do you invite a member of Congress, either to a health center or another place? We have what we call the Washington Update, which is our weekly advocacy alert that, provides that information, the key things. Where's that bill going? What is that bill doing? All of that is right there. As once you sign up for that, then you'd be able to get the activities that we have more on an urgent basis. When we send in an action alert, where we need somebody to contact the member of Congress, that's populated with a specific letter or email. So those are certain things that I have. But I think, just generally having an approach or a mindset that we all have a vested interest in the sake of our communities. Mm-hmm. And by taking time out of your day to do something, to have that commitment that either I'm going to engage in, it could be at the local level to get that stop sign in at the corner of the street, mm-hmm. or at the federal level when you're talking about billions of dollars that would support the rural healthcare system. Just that mindset is so important as a foundation. And then there's a number of different tools, like I said, that we have or others to really engage in the political process.
Joe, gosh, if I could be a fly in the wall when you were a staffer, I've been on the Hill. I've met with my representatives as because I put my money where my mouth is. I go to our Policy Institute every year in February. One thing that we have not touched on, if you don't mind, is, community health centers, your boards are made up. There are by mandate of people who live in the community. What is the value of board members and those who work within the clinic making their faces known and their stories known? What would that look like in sitting in front of a person like you, who in the mindset of a staffer, when board members who say, I'm a part of the community, I'm not a lobbyist or anything like that, here's our story. Do those work?
Oh, it's so incredibly impactful because, you really see as a staffer, I met with every type of provider group, every clinician type, all the guilds and the patient advocacy. And I loved all those meetings and those connections. However, when somebody comes in either from a business or an organization and says, hey, I'm going to lose money or I need a higher reimbursement or something, that's important. But when somebody is coming in and being, hey, I really need this care for me and my family, and I am dictating or I'm providing direction to this organization as to what they should invest in or how we can meet a community need, that's totally different, right? That patient board member requirement is a central thing that is just so foundational to the health center movement. Some of the other things, like health centers have to see everybody regardless of their ability to pay. Health centers have to have a sliding fee scale discount, right? So there's skin in the game for everybody. Those are, kind of some three differentiating features, but the patient board voice is so important in the policymaking sense, in the, again, at the practice level where, if a board member were to say, we don't have enough dental capacity, I know that this is an issue, or we need to start opening up more pediatric care in school-based health centers, right? That is so important because they're representing their community, right? They're really the voice. And so I think it's such a differentiating feature that health centers have that other organizations don't. And I really think that's part of the secret sauce that has made health centers successful. So advocacy is so critical. It's
critical. And I'm going to say that before we have to sign off, I'm going to say, build your bench. And what I mean by that is community health centers out there, make sure that other community influencers, key stakeholders, your insurance guy, local insurance broker, your chamber of commerce, your faith-based organizations. I don't believe that rural healthcare organizations do enough, and not because their plates are full, to make sure that other people in the community, it's not about helping shoulder the burden or feel the pain, bring along with you. What would it look like in our community if this community health center was gone tomorrow, for our employers, for our schools, so forth and so on? So don't go it alone. Get a choir. to go with you. And it's not just about those who are working in the healthcare space.
Yeah, I couldn't agree more. Those partnerships at the local level are so important. And that, again, back as a former staffer, when I heard about something about health centers from the local food pantry or the community-based organization, and they said, hey, this is important, that echo chamber is impactful as well. It breaks through in a different way. So totally agree with you.
Absolutely. Oh my gosh, Joe, it's been so great to have you here with us today. I mean it when I say be sure to let us know of any new policy updates where rural is concerned and community health centers. We'd love to have you back and let's talk about this. Let's check our watch and see where we are in 6 months, and we'll see if we're in a better spot than we are right now. So again, Joe, thank you. It's great to have you here.
Sounds great. Thank you again for the opportunity.
It is my pleasure. Okay, although we had to say goodbye to Joe, stay with us. We'll be right back with some closing thoughts on this last episode of The Rural Impact in 2025. I'll be right back. My thanks to Dr. Jacobs and to Joe Dunn, and to all of you for helping to make the Rural Impact podcast a leading podcast in this very unique space. What a year we have had. We are so grateful to our subscribers, to our partners in 2025, and they include the American Heart Association, the National Association of Rural Health Clinics, and the New England Rural Health Association. Again, we're so grateful for your partnership and collaboration and the investment that you have made in our content. Now, if your organization has an interest in expanding its rural reach, or if you would like to bring the podcast on the road, recording from one of your 2026 rural-focused events, be it on education, workforce, economic development, you name it, we are interested in those topics. So reach out to us and see how we might be able to make an impact together. All you have to do is email us at partners, that's plural, at theruralimpact.com. Pretty easy to find us. And while you're there, make sure that you subscribe. Leave notes, comments. We love when you do that. My thanks to Bria Corsaro and to Sarah Garvin for another great year. A lot of hard work behind the scenes. Couldn't do without you. And to all of you, I'm going to say this from my heart. I am sincerely wishing you peace, rest, and all the best in the coming year. We know these are not light subjects, and we know that millions of people living in rural America are struggling at this time. And so with that, I'd like to also remind you to take really good care of yourself and to the best of your ability, all those around you. We will see you again on a new season in a new year of the Rural Impact.